Good afternoon, everybody. Now we talk about anesthesia, second part of anesthesia. Intraoperative management, general anesthesia. What is general anesthesia? What is the definition of general anesthesia? General anesthesia is the induction, or we can say it's a condition of unconsciousness with the absence of pain sensation of the entire body through admission of anesthetic drugs. And this kind of unconsciousness is reversible, and it is used during certain medical or surgical procedures. And the purpose of general anesthesia is pain relief, analgesia, and blocking memory of procedure. We call amnesia, and producing unconsciousness and inhibiting normal body reflexes to make surgery safe and easier to perform. And the last one is relaxing the muscles of the body to easier perform of surgery. Yes, and the general anesthesia we say divided into four stages. Stage 1 is analgesia. In this stage, the patient experiences analgesia or a loss of pain sensation, but remains conscious. Or we can say, if you call the patient, he can respond, and he can sometimes he can carry on a conversation. And stage 2 is excitement. The patient may experience delirious and or become violent. Blood pressure rises and becomes irregular, and breathing rate increase. In this stage, it's typically, we say, sometimes we cannot perform surgery. Stage 3 is surgical anesthesia. During the stage, the skeletal muscle relaxes and the patient's breathing becomes regular. Eye movement slow, and then stop, and surgery can begin. And stage 4 is a too deep anesthesia, and in this stage, sometimes respiratory centers in the medulla depressed, and we say we should not make this stage reach. We should avoid this stage. And this is general anesthesia flu threat Mayer events. When we transport patient to OR, and we connect to the monitor, and then we give oxygen from mask, right? And also we open the IV access, and then we can induction use propofol, metomidate, or cytantol. And at this stage, we should maintain ventilation, and also we can give intratracheal intubation and secure and the tracheal tube. And the next stage is maintenance of anesthesia. And when we maintenance of anesthesia, we can use many types of techniques. And the last one is emergence of the patient and extubation, or just send our patient to PSU. Yeah, transport. And what kind of monitoring should we give to our patient? when they underwent surgery. We say ASA standard for basic intraoperative monitoring. It's two type of stand. Standard 1 is qualified personnel presence in operating room throughout all anesthesia cases. That means in the whole surgery, our anesthesiologists cannot, we say qualified anesthesiologist, cannot leave the patient. Yeah, we cannot leave the patient alone. And the standard 2 is during all anesthetics, the following parameters will be continually monitored. It is basic monitor, right? Including oxygenation, we usually use pulse oximetry, and ventilation, use vital volume and pressure of the airway and EtCO2. In circulation, we use heart rate, blood pressure, and the urine output. And the temperature, usually we can put 3 places. For example, skin is visual or flat. And pulmonary oximetry, usually we use this kind of machine to monitor the SpO2. This is a non-invasive management of patient's oxygenation and can be placed on finger, ear, or toes. You can see. And the EKG used for diagnosis of arrhythmias and the diagnosis of ischemia, heart ischemia, or diagnosis of conduction defect. And this is essential for the patient. Yeah. And EtCO2 monitor, you use the monitor monitoring ventilation and detect contain problems, contact certain problems, and if decreased, usually we can suspect low cardiac output or cardiac arrest, sometimes pulmonary embolism or circulatory disconnect or hypothermia. If the EtCO2 increases, we usually suspect maybe the ventilation is very low or malignant hypothermia, or maybe there is breathing. That means sonor lines does not work, or sometimes sepsis. For some major surgeries, we use intra-arterial blood pressure monitoring. And for some large surgery or for some very complicated surgery, or for some patients with severe coexisting disease, we should use intra-arterial blood pressure monitoring. And for some patients, we use CVP monitor. And CVP monitor, sometimes we can through internal jugular vein, sometimes we can through femoral vein. When we complete the monitor and when we open the IV access, we can start induction. Commonly used induction drugs is one is propofol. Propofol is rapid induction. Usually, we can give propofol 1 to 2 milligrams per kilogram. Rapid return to consciousness and anti-emetic, anti-emetic, and also used in total intravenous anesthesia. But the propofol also have some side effects, for example, pain at injection site or decreased blood pressure. And another one is etomidate. Etomidate also is a very rapid induction drugs and also rapid awakening, and it can supply cardiovascular stability and decrease, and also we can see, so it is suitable for patients with sometimes maybe an elderly or elderly patients or patients with some special disease or weak patients. But the etomidate also has disadvantages, for example, pain when injection, and sometimes suffer from involuntary skeletal muscles movements and increased postoperative nausea and vomiting, and also at disadvantages of etominate of suppresses adrenocortical functions. And commonly used IV induction drugs is also include opiates. Opiates can be rapid onset, and also it can decreases sympathetic nerve system tone and decrease heart rate. And also it depress ventilation. Sometimes it can cause mycosis, and sometimes can cause nausea and vomiting after operation. Now the drugs available is fentanyl, morphine or sulfentanyl, lumefantrine. We can choose according to the different individual patients. And another drugs essential is muscle relaxants. Muscle relaxation and paralysis can theoretically occur by interrupting function at several sites. For example, central nervous system, myelinated somatic nerves, or unmyelinated motor nerve terminals, or nicotinic acetylcholine receptors, or motor end plate, and muscle membrane or contractile applause. Most neuromuscular blockers function by blocking transmission at the end plate of the neuromuscular junction. And now in clinic, we usually use muscle relaxants, including deprioritizing relaxant, acetylcholine. It is rapid onset and rapid return muscle stress using rapid sequence induction usually. But this muscle relaxants has adverse side effects. For example, it can cause cardiac arrest and hyperemia or myalgia. And when we induce the patient, we should consider the airway management, and we should evaluate the airway and give the tracheal intubation. Complications usually direct, we usually direct laryngoscope and intubation. As for example, dental and oral soft tooth trauma sometimes may cause hypertension or tachycardia, and sometimes can cause cardiac arrhythmias or myocardial ischemia, or inhalation or of gastric contents. This we should avoid. And after the induction of anesthesia and give the tracheal intubation, next one is we should maintain anesthesia during the operation. The goal of intraoperative care is to deliver adequate, safe anesthesia while maintaining hemodynamic stability. At this stage, we can give many drugs to maintain the anesthesia, to maintain the patient to unstable, unmovable sometimes, right? And no pain and lost of consciousness, something like that. So, and in this stage also we should manage the fluid and the blood to maintain the hemodynamic, and also we should maintain the electrolyte balance or acid-base balance, right? So sometimes we should give blood gas analysis, and also we should consider about positioning. When we position the patient, we should pay attention for some conditions. And inhalation, when we maintain the anesthesia, we can use inhalation anesthetics. Usually nowadays in the hospital, common used inhalational anesthetics, including for example, isoflurane, sevoflurane, desflurane, or something other drugs. And also we should use some drugs to maintain the blood pressure, to protect the cardiac function. For example, we can use sympathomimetics to maintain the blood pressure. Or for example, synthetics, vasopressors, something like that. And also we can use catecholamines, for example, dopamine or norepinephrine, to maintain the cardiovascular function. The inhalational anesthetics, we say, it's a chemical compound possessing general anesthesia properties that can be delivered via inhalation, right? And when we deliver inhalation anesthesia, we should consider some important concepts by heart. For example, inspired partial pressure. Inspired partial pressure means kind of gas concentration. If the inspired partial pressure higher, it increase input of anesthetic to offset uptake. And this is the objective for inhalational anesthesia to achieve a constant and optimal PI in the brain, right? You can see this is the process of the inhalational anesthetics goes in flowing vaporizer to the lung, and then to the circulation, and through circulation to the brain. And brain is the action location, right? It's action site. And inhalation anesthetics, when you use when we use inhalation anesthetics, and we should also consider what kind of factors will influence the induction velocities or emergence time, right? This is many factors influence this one, right? And the conception effect, we say factors determine transfer of inhaled anesthetics from anesthesia machine to lung, including concentration effect and alveolar ventilation. If alveolar ventilation higher, it can increase the rate of anesthesia. And the anesthesia breathing system, for example, volume and the solubility of anesthetics or gas flow rate. And we also should consider second gas effect. What is second gas effect? Second gas effect is high volume uptake of one gas